Okay, so thank you guys for being here first off. We appreciate your time, judges and other participants and guests and mentors and all that stuff. We really appreciate your time. So we are the Mind Health Team company. And we as a company and a team are dedicated to delivering healthcare centered around you, as you can see up here. And defining you, you can be the patient, you could be a hospital or another healthcare provider, and you could even be a government-sponsored program such as Alabama Medicaid. So we here at My Health Team are driven to providing innovative solutions for today's healthcare problems. And so with that, I'd like to introduce our team. So my name is Josh Raj. I am a graduate student in the UAB Masters of Science in Health Administration program, as well as the Masters of Business Administration program.
I'm John Berkery. I work for Blue Cross Blue Shield of Alabama, and I'm in IT.
Hi, my name's Ahmed, and I'm a co-founder of a telemedicine startup, Doc247, which is actually based out of Innovation Depot here. Thanks.
Hi, my name is Alex. I'm a student at Smith College and current Impact America member with AmeriCorps.
So we wanted to start by defining the problem for you. And so broadly, our problem that we are here to solve today is the overutilization of emergency rooms by Medicaid patients. And that's just the plain and simple definition of a problem. And this has created a lot of underlying problems that we will address as we go through our presentation.
So when we look at this problem, we kind of approached it and try to say, well, who are the impacted players in this whole problem? We tried to empathize with them. So we identified kind of maybe three main impacted players. The payer, in a sense, the government, the Medicaid provider, the patient, and then we went on and even looked at the provider, so to speak, and how can they all work together, and what can we do for those three entities to work together to achieve some type of successful model. Here, what you see here is from the payer aspect, Medicaid spend annually. If you can, I know it's far away, but if you can see it, about 40% of this pie chart represents inpatient, outpatient, and mental health. So 40% of that annual cost for a Medicaid patient is spent in those areas. And there's about 40% kind of represents about $2,000 annually, and then multiply that by the number of members in the state, which is about 1.2 million. It's a large amount of money that's available there to impact. Next thing we did from a patient aspect is we really went out into the ER rooms around town. We kind of said, what's going on? We tried to visualize and talk to some people. We actually were able to get a story from a man who had recently had an ER experience where he and his wife brought their young child into the ER room about 10:30 at night. His child had some injury to the arm, just like immobile. It was very uncomfortable. Mom and dad were very nervous about this whole thing. And he was in line behind somebody he found out that had an allergy, some allergy issue, and some flu-like symptoms. And he was very nervous. He was like, why am I waiting? Why is my uncomfortable child waiting behind something that can be handled the next day, in a sense? So he got to talking to them, and they were like, well, yeah, it can be handled the next day in some urgent care facility or after-hours facility, but they aren't open right now. They are not available to me. I can't go during the day tomorrow because I have a job. I can't leave my job. I don't get paid when I leave there. So it's like, this is the only thing available to me at this time. I'm going to use it. And yeah, it's not convenient for me either. I'm here. I'm supposed to be sleeping, preparing for the next day. I had to gas up to get here. I had to spend all this money to get here. I had to bring blankets. I had to bring pillows. Just this whole, I don't want to be here, but this is the only thing they're offered to me. Also, from a report we found online, the Office of Inspector General, along with the government, did some research and really identified three areas where they can improve their Medicaid population from going to the ER rooms. And the first thing they said was if they could create or increase the use of some type of managed care prepaid option. They also said if we can offer some extended or off hours of care, and then if we could also look at a way of a tiered way to approach the level of care done in the emergency room. then finally, we also saw from a provider standpoint this really increase in these patient-centered medical homes. You might be aware of these, but they're just kind of groups of medical specialists or medical professionals, whether it's primary care physicians or somebody specialized in certain areas where they really focus on the long-term care of an individual, whether it's acute, whether it's chronic, whether it's preventive care, and they do so through the use of technology. And with that technology, they really try to manage cost and efficiency and quality in what they give to the patient. So you've got these three things working in this environment right now. From there, you can also kind of see, here is the availability of a lot of patient-centered medical homes across the nation. You can see they're dominant up in the Northeast, and they're really just spreading out there. So there are these kind of functioning teams of medical availability there for patients. And with that, that kind of drove us into the direction down, what are we going to do? How are we going to solve this problem?
So we'll start with the solution, and the simple kind of definition of the solution we're trying to solve is the solution we're trying to give is expand the availability of primary care. So we as a company want to take that concept that's trending upward, this patient-centered medical home concept that is gaining ground in the healthcare field, and we want to expand on it to efficiently change behavior of Medicaid patients and make them more inclined to use primary care. We're trying to do that through the use of technology, through the use of more effective cost channels to eventually improve patient outcomes and experience. And so what we decided to do was take that patient-centered medical home model and shift it to more focus on Medicaid as well, so more of a Medicaid home model, Medicaid health home model. And so many facilities can decide to create these care teams in ways they see fit, but with the product that we're going to show you coming up, we thought this would be the best model for what we are going to provide as a service. And that is to focus, you have the patient at the middle, and you have the primary care physician who's going to deliver the majority of the clinical care to these Medicaid patients. As sort of a lot of other models use a layperson or maybe a case manager to kind of be the patient navigator type role, we decided to put an LPN in there so that it can increase patients' trust that they're always talking to someone who's has some clinical knowledge. And so that LPN role will act as a navigator to help set up appointments, to take any calls, and to deal with some issues the patient might be having that does not need to be addressed with the primary care physician. The LPN will also be able to set up appointments with a health coach and health educator. And you'll see why those roles are more important as we move forward. But these two roles really kind of maintain constant contact with the patient. We'll have the ability to make home visits if need be for the more frequent users of the ED, things along those lines. And then we included a mental health component because we thought that mental health is so important, especially for people who are typically low SES. And mental health can be such an answer of comorbidities. There's a lot of things that can go wrong with mental health. And so if we can focus on mental health, provide that kind of care to these patients, we believe that will help reduce their usage of the ED as well. And so getting into the product that I mentioned, we created an app. So this is the My Health Team app. And the way this works is it is centered around these care teams that we mentioned earlier. And this is all at the fingertips of the patient. So you'll see in the darker circles around the outside, these are all services that the app will provide, all at the fingertips of these patients. And so with one click, you'll be able to access their care team with a call, and they'll go to that navigator who will then direct from there. They have a refill prescription button. All they have to do is click it once, and it sends a notification to their team that, hey, I need to refill my prescriptions. Through wearable devices, we can monitor their vitals, and that part of the app is connected to the specific facility's EHR so that the team can constantly monitor how these vitals are going and whether they need to reach out and call if their vitals are going off the charts or in the wrong direction. For the more frequent users of the ED, we will provide a tablet that will provide constant or immediate access, to a teleconnect service. So they can hit that button once and there's a video conference will pull up. And then two other services will provide a facilities near me button where they can click the button and find out where are the urgent cares near me, where are the primary care clinics near me, instead of just relying on, oh, I've heard UAB's name, I'll just go to the ER there. They could end up finding out there's an urgent care a mile down the road from them that they had no idea was there. And the last thing is alerts, which is incoming and outgoing messages with their care team that can provide just an actually have created a demo for you of the app. So I'll turn that over to Alex. Take care of that.
So we created a prototype of the My Healthcare Team app, and this is designed to be a streamlined app that'll help connect patients with their healthcare providers and establish those bonds of trust and that feeling of accessibility that Medicare patients are so often lacking. So the first button on there is our most important. That's the Call My Team button, and you can see, have it on my phone here. I can just click this button right here to call my team. And if I'm a Medicare patient and Josh is my healthcare navigator, this button will automatically call his phone and let him know that I have a problem and I need help. And because you're connecting with someone who can help you navigate through the process, the ER doesn't have to be your default choice anymore. Yeah, super cool. So anyway, because of this, now that LPN or that healthcare navigator can help you decide which option is the best for you rather than just defaulting to the ER. And our other options here, so we have Refill RX, which will send a message not only to your team, but can connect you straight to any pharmacy you want. And also Care Near Me will connect you straight to any care facilities near you that you need to talk to, or alert you to any urgent cares or primary cares in the vicinity.
So as you can see by the app, it's incredibly simple. So for the older populations, it's incredibly easy to use. It's one click for everything. And so that's really what we were going for in terms of the design of the app. And so we focused a lot on the patient and that care team model, but we also believe as a company that we can create change and improve this problem through working directly with the EDs. And that's where our second program comes into play. So this is what we call ER PATS, or Patient Aligned Telemedicine System. And so the way this system works is a patient comes in and is triaged like normal in the ER. And if they're listed as non-emergent, oftentimes they have to do a lot of waiting before these emergent conditions are dealt with. So instead, we have created a design through our telehealth program, which is connected to your EHR as well, just like the app, where you can set up an adjoining room next to your ER that has however many computers you may think you need. And the way this works is that they get triaged as non-emergent, especially for Medicaid patients. They have the option to go into this telemedicine room, sit down in front of the computer, and get immediate access to a primary care or general practice resident on the other side. And so they still think it's a physician, and they are a physician, but we won't use necessarily the term resident, so that kind of belief that they are competent is still there. And so basically, this will be used as a way to give primary access to people who go to the ED. So the app's not gonna, everyone's not gonna be compliant with the app. You know that. People are still gonna go to the ED. So it's important that they have an option once they get there to receive primary care. And this has the ability to lower your costs because one, you're using a resident, so you're not paying a full-time physician for you're not paying that high of a cost for a physician to monitor these. And this is delivered through the primary care route, so it decreases the cost. The hospital's not eating the cost of having this person go through the ED. So that's kind of the two things we really have set for this program. And so just to kind of explain why these have value, we decided to focus on the 5 A's of access and why and how these two programs that we've just presented before you provide value to. So in terms of affordability, the app is free. We use an LPN as the patient navigator who has a lower salary than you could use a nurse or even perhaps a case manager. And then as far as ER PATS, that's also free, but you will reduce your cost because you're not giving free ED care to these Medicaid patients like you were if they had just used the regular ED. And we're using residents, which is also a cheaper version than using a primary care physician. In terms of accessibility, it's on the phone. Everything is at your fingertips that you saw on that app. Everything's one click away, so it's an extremely accessible program. You can even have home visits with those health educators and those health coaches. So that's another extremely accessible feature. As far as accommodation goes, the ability for our team to respond in a timely manner, we believe, is something that we can definitely control because they will be managing a certain amount of population. And then the ER PATS offers after-hour visits as well. So that kind of can solve a little bit of the primary care problem of people not being able to access it during work hours. And in terms of availability and availability is similar. It's available right at their fingertips. They have this one-on-one connection. And then acceptability, their confidence is still there because they feel like they're not alone caring for themselves. They have
So a patient's already, say, enrolled at Baptist, and you know who's a frequent flyer that's abusing the system, basically coming to your ER multiple times. That's the person you give them a tablet and a couple of wearables to either get their blood pressure reading, and you're also able to teleconnect, like have an instant video connect with them. But other regular patients, you just give them the app, it's free. They could get text messages, so you're sending them basic everyday text or a picture saying, hey, did you eat your veggies today? Did you walk 200 paces or whatever? So basically, this whole thing is towards the doctor or the hospital. So hospital is your main customer, and then they in turn give it to their patients.
And that health educator and coach role, they act together to more consistently monitor their patients and, reach out to them on a weekly, bi-weekly basis, depending on how much care the patient needs. And they can continue saying, hey, remember you have the app, make sure you use that. They can constantly keep putting that in your ear and the benefits of the app, how that goes. So that's how we'll get it to them, and then those two roles are how we'll maintain use.
So the second part of my question is, how are you making me want to use it? How are you incenting me as your target audience to use this? I understand now how you're going to get it to me, but how do you make me want to use it?
So you as a patient or you as a
You as a
organization?
patient.
Okay.
Use it.
So one of the ways that you're going to incentivize people to use this is firstly because it gives you such the feeling of like access and of trust between your doctors. It will seem like the main link between you and your healthcare. And then the other thing you're talking about, like developing this idea along the line, obviously not in this version, was putting in incentives along the road. So like, did you go to a primary care physician? Yes, you get like a little reward for going to a primary care physician every day in somewhat of a gamified way. Or like checking in with your people, like you get rewards for doing these things. And that's something we could further develop this idea down the road when we get more user data about how people actually use the app.
And the remote patient monitoring part of the app makes patients feel like they're not alone. It makes you feel like they always have someone who's monitoring their, and so if their numbers are off the chart, or they don't understand when their blood pressure is high, or if they're diabetic, what's the high blood sugar range. They know that they have someone back there monitoring them so that they will eventually get a call and some help in that regard.
Did you give any thought to putting a social worker in your team?
Yeah, so that mental health component that you saw on there, mental health practitioners or nurses, things like that there's not a very large supply. There's a need for them, and so to fill that need, sometimes we thought of putting in a social worker into that role, someone who understands the concepts of maybe what someone will be going through on a mental health capacity, and then we've also kind of created a strategic future goals to add some extra people to the care team. For example, a social worker could also add that on top of mental health, so you have both those components. And we also thought about potentially adding another LPN who already works like a night shift, so that they have someone to contact, they can contact even at night.
So did you go back, you got 1.5 million enrollees, and you've got not a whole lot of money to work with. You've added a bunch of people into the system. Have you worked the finances out to support?
Yes, we have. We actually create a hub, and then we divide a population, say Region B. You have a population of, we start out with that 5, a doctor and the other workers. We start out with 1,000 population, and we work the numbers. First year, the expenses were around $949,000, and the revenue model that we worked out would bring us $840,000. So first year, we're actually losing $109,000. But then once you start working and adding more of those hubs, there's extra revenue because you're saving 20%. We saw that there's 20% savings. And we can share those with you.
So you make a lot of key assumptions in this. One is, to go to Teresa's thing, is you're looking at a very marginalized population. So have you looked at the prevalence rates of smartphone technology, the adoption rates of that, the propensity to use technology for healthcare? So what about where this population is located? Do they have access to Wi-Fi? Do they have the money to purchase the data? Because those are all kind of,
Yeah, so actually we did research researched that, and so for populations making under $30,000 a year, about over 50% of them have access to smartphones. So people do have access to this technology, and for 10% of those, in fact, smartphones are their only access to the internet. So doing this through a smartphone system is actually the best one. And then in terms of are they using smartphones for healthcare access, the number 2 thing that smartphone data plans are most used for is to look up questions about medical conditions. You can just, AT&T can find this by seeing what people Google. So people are using their smartphones to look for medical conditions, and people have them. And then in terms of the Wi-Fi, I believe you have some answers.
So right now, my telemedicine company, Doc24/7, is running a pilot in rural Alabama. The patients that do not have access to strong Wi-Fi or strong network signal, those people will get text messages and phone, which we mentioned earlier. And we also built in email and text messaging between providers. And our system actually runs at less than 1 Mbps on video. And we've tested it several times. And our pilots saved a ton of money with keeping people out of ER.
Can you talk about ER paths a little bit more? I just want to make sure I understand it. So you show up at an ER, it's a non-emergency situation. You're sent to a room with lots of monitors where you can then speak with a primary care provider, albeit one that isn't as high up the chain, perhaps.
Yeah.
Where are those doctors for one?
So,
Like, go down site?
well, that would be something, yeah, so you could take residents who could potentially be on site, but maybe not, because the space is limited in ER. A lot of facilities, I think it would be beneficial if facilities were able to build like an urgent care right off, their ER room, so they could send people there, but people just don't have the space for that. And so in order to maintain space, they could be on site. We could also collaborate with other institutions in the state or things like that. That's farther down the road. But in terms of how the process works, yes, they come in and triage, and the room is manned by one of your staff members, hopefully a nurse or an LPN, someone with clinical experience. And because the telemedicine system is connected to the EHR, they get that consultation from the primary care physician. And if they need a prescription, that nurse is able to then go ahead and just print them off the prescription right there, or go through that process with them as they are there. And strategically, we've thought about a little bit down the road too, and potentially doing that, triaging these patients and working with the ambulance services and give them a tablet, so that for people they pick up in an ambulance who they suspect might be non-emergent, can call in, via video conferencing, and kind of prep these patients and decide whether this person is emergent, whether, how we can better get them into this program and get there. And so that's a little bit down the road, but that's some of the strategic thinking that we had going into. So it saves them from having to potentially wait in the ER for a long time, and it still gives them a primary care method to go through instead of emergency care.
When you think of telemedicine, typically you think you're at your house and you talk to a doctor from somewhere else. So this idea of on-site telemedicine feels, are other people doing that? Did you come up with that? It feels new to me.
There's a startup that does that today. Basically, if someone's already at ER, they refuse to go to primary care, they just are there. And they're allergy or cold. I mean, what do? They have to see a doctor, might as well get them in the ER, manned by LPN, you have multiple booths. You just go in, same people, you're saving your actual ER department cost. And as far as, to add to that question, about getting the residents, right now there's legislation that you can't do this multi-state, like you can't use a doctor from Mississippi to see a patient in Alabama. So for now, we'll be using it here, local doctors based out of Alabama, licensed to practice here and whatnot.
Well, thank you guys for your time. We appreciate it.
Thank you so much.